Bonjour à toutes et tous. Bienvenue à la série de conférences en éthique de la santé, édition 2024. Je me nomme Éric Racine, je suis professeur titulaire de recherche à l'Institut de recherche clinique de Montréal et à l'Université de Montréal, aussi prof associé à McGill. Et comme vous le savez, pour les personnes qui ont assisté à d'autres conférences de la série, cette année, on aborde l'éthique et les cultures organisationnelles dans le milieu de la santé. Et déjà, après quelques conférences, l'été s'en vient, on est déjà à la moitié de l'année et on a eu la chance d'avoir des présentations qui étaient plus englobantes et qui présentaient des notions d'éthique et de culture organisationnelle de manière générale. Et on a aussi eu droit à des conférences qui ont porté sur des projets spécifiques d'intervention organisationnelle, de projets de sensibilisation et de soutien. Et je me permets de rappeler les deux derniers événements auxquels on a eu droit le 28 mars dernier. Le professeur Yves Boisvert, qui est prof titulaire en éthique et intégrité du service public à l'ENAP, a présenté sur les fondements de l'éthique organisationnelle d'un point de vue des sciences sociales et de l'étude des comportements. Et le 25 avril dernier, nous avons reçu Jacinthe Boisvert et Anne-Valérie Fournier du CIS de la Montérégie-Est. Leur présentation s'intitulait « Une culture de santé globale et d'équilibre pour nos travailleurs de la santé ». Puis, elles nous ont expliqué pourquoi il est primordial pour les établissements de santé de prioriser la santé, l'équilibre et le développement de leur personnel. Donc, c'est une présentation d'un projet fascinant. Et maintenant, today, we are welcoming Zena Sharman, who is a writer, speaker, strategist, and a LGBTQ health advocate. She is an engaging speaker and also an active writer and editor of volumes. For example, I'm bringing to your attention a number of her recent volumes. 2021, The Care We Dream Of, Liberatory and Transformative Approaches to LGBTQ plus Health. And two other volumes, at least, probably maybe others I'm not aware of. There's The Remedy, Queer and Trans Voices. Here they are. Thank you for showing us these volumes and making us eager to learn more. And so 2017, The Remedy, Queer and Trans Voices on Health and Healthcare. And before that, Persistence, Always Butch and Femme, edited also with Ivan Coyote. So thank you so much for being with us, for joining us in this series. And I believe, I don't want to predict, but I think a very important contribution to this series to bring our attention to the LGBTQ plus community and their experiences of care, their aspirations of care. And the talk is appropriately titled LGBTQ plus health care praxis, building more equitable and just futures today. I love this title, and I'm looking to, as others online, many others online, eager to learn more about your vision, your experiences, and all the messages you have for us today. And as usual, we will have a good 10-15 minutes for Q&A comments at the end. And for those who want to write their comments or questions in French, I'll do the live translation. Thank you.
Thank you so much, Eric. And thank you again for the opportunity to be here. I am really pleased to be joining you today. And I'm coming from unceded Quechan territories here in Duncan on Vancouver Island. And I do have a PowerPoint, so I'm just going to share my screen. And I also really appreciate all of you who are doing the work of listening to me in English, which may not be your first language. I speak some French, not enough to feel confident communicating these ideas the way that I can in English. So thank you and merci for listening. And if I go too quickly at any point, just let me know, and I'm happy to slow down to make it as accessible as I can. And I just want to get my PowerPoint to cooperate, and then I'll get started. And I want to acknowledge as well, I come to this work as a writer, certainly, as someone who trained as a health services researcher and studied care and care work in my master's and PhD. But really importantly, I also come to this work as a queer person, and so my knowledge is rooted in my lived experiences, what I continue learning from the communities that I'm a part of. And never want to suggest that I have, the definitive take on any of these things. My knowledge is situated and limited by who I am, as a white person, as a settler on Indigenous lands, as a non-disabled person. So holding to the complexities of what I know and what I don't know, but hoping that this can be a rich and engaging conversation today. So just to give you a little bit of a sense of what I'm going to cover, I want to do some context setting. I'm really thinking about LGBTQ plus healthcare experiences and health inequities and what these might signal to us about the cultures of care that exist within our health systems. I'm interested in looking at systems and cultures and challenging narratives of brokenness in relation to our health systems and systems of care. And then to think about care ethics in practice, thinking of care and ethics as something we do, and I sometimes say I'm more of a praxis person or a practice person than I am a theory person, but I like to engage with and learn from theory in my work, but always thinking about how do we apply it, right? Which I imagine is that same spirit of pragmatism that the unit brings to their work. And then I'm interested in thinking about both care as control and unjust and harmful uses of power in the context of LGBTQ plus healthcare, but also care as world building and possibilities for transformation. So that's a big picture overview, and we'll have time for questions at the end. So if there are places where you need me to elaborate further, I welcome hearing from you. So I want to begin with trust and safety. And, I've been doing LGBTQ plus health advocacy work for more than 15 years. And I need to acknowledge, I still feel a little bit shocked when I meet someone who's surprised to learn that queer and trans people, LGBTQ plus people, I might use those terms interchangeably, and certainly, indeed, many people from other communities don't trust or feel safe with their healthcare providers a lot of the time. And it makes me ask the question, what might it feel like to go into, walk into, roll into an ostensibly caring institution and feel an instinctive sense of trust and belonging? And I think importantly, to ask ourselves for whom this might be impossible or possible and why. And then in turn to ask ourselves what this might signal to us about how LGBTQ plus communities experience the cultures of care that exist within our health systems, and ask how these cultures impact LGBTQ plus people's health and our ability to access the care we need. So I want to ask the question, when care feels unsafe, what do you do? And, we certainly have evidence, certainly from the US, from Canada, telling us that LGBTQ plus people tend to avoid accessing needed healthcare out of fear of stigma, discrimination, or mistreatment. So some examples would be from the Trans Pulse Canada survey. 12% of respondents to that national survey of trans and non-binary people in Canada reported avoiding going to the emergency room despite needing care because they fear discrimination. And in the United States, the most recent US transgender survey found that 24% of respondents did not see a doctor when needed in the past 12 months due to fear of mistreatment. And of those who had seen a provider, almost half, so 48% of respondents, reported having at least one negative experience with their care providers because they were transgender. Surveys show that lesbian, gay, and bisexual patients in this particular study I'm referring to reported that stigma most consistently influenced their communication with providers and decision-making about where to access care. So perhaps more appropriately, fear of experiencing stigma or strategies for mitigating against stigma. And certainly we also know that, again, another example, lesbian and bisexual women tend to avoid screening for cancers like breast or cervical cancer and sexually transmitted infections because of feelings of distress associated with medical visits. So just a few examples of the health impacts, and certainly some of these discriminatory experiences that people report. So when care feels unsafe, what do you do? Certainly, you might avoid getting the care you need. And importantly, in LGBTQ plus communities, as in many others, we care for each other and ourselves. And I also think it's so important to emphasize, and my work explores this in depth, the ways in which LGBTQ plus communities develop and share sophisticated knowledge and skills for advocating within the systems that exist and navigating those systems. So how do we advocate for ourselves, our community members? How do we identify safer providers or places to access care or who to avoid? But also developing really important skills for subverting formal systems of care. So sharing care practices that enable us to care for ourselves and one another outside of formal systems of care in very highly sophisticated ways. And there are a multitude of historical and contemporary examples of this that I can speak to if people want to learn more. I think it's also important when thinking at the systems level to point to how knowledge gaps lead to care gaps. So certainly there's a robust body of evidence telling us that healthcare providers receive insufficient education and training on caring for patients from LGBTQ plus communities. You know, there's data from about 15 years ago telling us this from a survey of medical schools across North America. But there's also studies published in the last 2 years that are telling a very similar story. So in one survey of graduate level MD, PharmD, and Doctor of Nurse Practitioner students reported that their education, basically fewer than half of them reported that their education prepared them to treat LGBTQ plus patients. And in a recent paper published just this year, the quality of LGBTQ plus health curricula at US medical schools was rated as adequate or lower, was what the study said, resulting in gaps in knowledge, confidence, and preparedness among trainees. And another study showed recently that an average of 10.7 hours are dedicated to transgender health topics in graduate medical education. So it's also no wonder that we have many healthcare providers who don't feel well equipped to care for the LGBTQ plus patient in front of them. And another facet of this that I think is important to acknowledge is LGBTQ plus people, you know, we aren't just your patients, we are also your coworkers, your students, we're everywhere. And I think when we're thinking about cultures as well, and organizational cultures in particular, it's important to look at the fact that we also know that LGBTQ plus healthcare providers and trainees experience harassment, discrimination, and mistreatment by coworkers, senior colleagues, and patients. So we hear, for example, transgender and gender expansive physicians reporting experiencing stigmatization from colleagues who conflate their gender identities with mental illness. We hear from LGBTQ plus healthcare providers who are not out as members of the LGBTQ plus community at work because they fear losing their jobs or experiencing harassment and discrimination. There's data showing us that LGBTQ plus surgical residents commonly report mistreatment, often by their attending surgeons. And those experiences of mistreatment are associated with increased suicidality. And LGB, so lesbian, gay, and bisexual medical students who experience high sexual orientation specific mistreatment are 8 times more likely to develop burnout compared with their heterosexual peers. And again, these are all recent studies. So I think this is another important facet to bring in when we're looking at the cultures of care. So when we think about all of these things, certainly we have lots of data pointing to LGBTQ plus health inequities. And I think the important thing to understand here is that the health inequities we experience are predictable outcomes of health systems that emerge from and operate within contexts of systemic oppression and structural violence. So again, I can get into the disparities, but I always try to think big picture before I'm reeling off lists of disparities to you. But just as a couple of examples, there was a cross-sectional study of more than 30,000 sexual and gender minority adults in the United States that found higher odds of anxiety, depression, HIV diagnosis, and tobacco use disorder, as well as lower odds of cardiovascular disease, kidney disease, diabetes, and hypertension, and substantial variation across groups for odds of cancer, asthma, and substance use disorder. And a StatsCan study of functional health difficulties among lesbian, gay, and bisexual people in Canada found that a higher share of these folks aged 18 or older reported experiencing difficulties in functional health. So over half, or more than 52% of LGBT adults reported experiencing at least some difficulty in any of the 6 domains of functional health, significantly higher than heterosexual adults who reported it in about 38%. And then we also see from a literature review by Rainbow Health Ontario that racialized LGBTQ plus people have a higher prevalence of asthma, some cancers, heart disease, COPD, hypertension, kidney disease, smoking, and stroke. So I think it's important to remember that these inequities can sometimes be perceived or narrated as forms of ill health and debility that reside in individual bodies or are the result of individual choices or risk profiles. But I think it's so important to contextualize them in relation to how they are associated with and exacerbated by discrimination, violence, trauma, toxic stress, homophobia, transphobia, racism, ableism, poverty, food insecurity, the many social determinants of health that we see impacting people's health, as well as experiences of criminalization. So these are all impacts on LGBTQ plus people's health. So thinking about all of this, I want us to zoom out and think at the level of systems. And I really appreciate this quote from Dr. Paul Battledon, which is, every system is perfectly designed to get the results it gets. So this, I think, is important when we're thinking about some of the data I just shared with you, to be saying, well, gosh, who are these systems constructed for and who constructs them? Who is the typical patient imagined to be? But I think also who is perceived as worthy of care and who is seen as a reliable and trustworthy narrator of their own experiences. And I also just want to take a moment to show you 2 diagrams, because I'm struck actually by the parallel between what I want to share here. So this is a model from Edgar Schein. It's a way of looking at essentially the dimensions of organizational cultures, just one way of thinking about this. But the main thing here is he talks about this idea that there are these cultural artifacts, they're visible things that we can notice and see about organizational cultures. Perhaps it's the physical environment of a space. Maybe there's a rainbow flag on the wall, for example. And then there's the espoused values of an organization that they might put forth. We might hear a commitment to equity and inclusion, for example. And all of those are good things. However, I think it's also important to look at that deeper layer of the underlying assumptions that actually really deeply shape cultures in organizations and certainly within our care systems. And what I want to do here is juxtapose this model with what's called the iceberg model, which is a way of thinking about systems change. And I think a really useful thing to understand about this particular model is that it shows us that there are many levels of a system, and only some of them are visible to us, those things happening above the surface. So when we are looking to change a health system, for example, we need to understand, not just what are the events or the patterns of trends we can see, but actually to get deeper down to the level of understanding systems and structures and the mental models that shape those. So what stood out to me here and why I wanted to share this with you is noticing those mental models at the bottom level here and the underlying assumptions of organizational culture. So keep those images in your mind because this, I think, is where I see a thread. So the top of this slide says, the system isn't broken, it's working as designed. And I have increasingly found this idea a really useful entry point into understanding drivers and possible solutions to LGBTQ plus health inequities and barriers to care. So I think certainly that our systems of care can sometimes have a taken for granted quality, this idea that they've always been there, they've always been like this. But I think that this can limit our inquiries into why they work the way they do, the outcomes that they produce, and the possibilities for transforming them. And I want to challenge the notion of a broken system because I think that that also shapes our sense of the kinds of solutions that are possible or the kinds of transformations that are necessary. So if you think about the health inequities that I showed you, for example, or some of these barriers to care that I've just articulated, those are very understandable to me in the context of the design of the systems of care that we have. So when I think about health systems, I'm in a practice of asking myself, who made it, who leads it, and who is it for? And if you're someone who's working within these systems as a clinician or in another role, I think it's also worth asking yourself, what does this system ask of me, and what are the ethical implications of those demands? And this is where I want to get into care ethics. And so this is a place, where I am interested in thinking about care ethics in particular as something that we do. Absolutely, care ethics are an important space of theorization, of thinking about care, but I am fundamentally really interested in practice and praxis. And I think about care ethics actually as an active process situated in place, relationships, and accountability, recognizing that we all give and receive care in our everyday lives, perhaps for our loved ones, for our community members, through pay. My children are in school and daycare right now. That is paid care work being done by other people in the community, right? So I think these are really important dimensions to think about when we contemplate the ethics of care. This is not an abstract thing happening over here. It is something that we are each living in the context of our lives and situated experiences, including professionally for many of us. And I also think it's important to point to the fact that our care practices can be a means of diagnosing where our ethics collide with our circumstances. And Sarah Clark Miller in the book Care Ethics in the Age of Precarity talks about the ways in which these collisions can cause moral injury and relational harm, when perhaps the ways in which we desire to care are rendered impossible by virtue of the circumstances we find ourselves in. So I also find care ethics to be really useful as a site of possibility, as well as a means of perceiving what is understood as ethics and assumed to be ethical in our professions and institutions. And similarly, I really appreciated a recent paper by nursing scholar Jess Dillard-Wright, who talks about and distinguishes between what is received as ethics in nursing and what is possible for nursing. So nursing ethics, I should say. So there's this theme that I will come back to around, again, what are the ethics and the practices of care that might be embedded into or afforded by the systems we find ourselves in as workers, as patients, as family members, as community members, but also what kinds of ethics might become possible, particularly if we can think kind of beyond the frames that have been offered to us. So in this same paper by Dillard-Wright, she asks this question about received versus possible ethics and says in the paper, what is received, that is, what is perceptible or legible, is as much an ethical question as it is any other kind of question, molded by what we value, how we prioritize, what we understand as knowledge, which histories we accept, and what we forget. and highlights the dynamism and world-building possibles inherent in the idea of ethics as something we do. So again, this is a place where I see a connection with the idea that our horizon of possibilities can begin to shift when we accept that the systems that we are working within and or perhaps working to change aren't broken, they are working as designed. This can be challenging to reckon with, in contrast to the idea of a broken system that we can fix if we just work hard enough, find the right solution, get the right evidence. But I also think it can be freeing, enabling us to imagine alternative possibilities beyond the constraints of existing systems. And I have also really found very useful the work of Akemi Nishida in her 2022 book, Just Care, where she talks about this notion of care being a modality of power dynamics. Because I think a parallel I see between care and our health systems is that they can both take on a taken for granted quality. This notion that I know what care looks like, or we care for everyone. But in fact, care operates and is experienced in a myriad of ways. So in the book, Just Care, Nishida talks about how care can be used to enforce top-down, dominant power, yet simultaneously can be exercised at a grassroots level to resist dominance and enact transformative power for a more just world and way of living. So when I think about this framing, I'm interested in asking some systems level questions, certainly that I would encourage you to reflect on. So when we think about this distinction between top-down dominant forms of care and care that enables grassroots resistance against dominant power, I find it useful to ask, what forms of care do our health systems, structures, and organizational cultures enable? What forms of care do they limit, suppress, or discipline? And what do they ask of carers and care recipients? Going deeper into this idea of care as control, I really find that Nishida's work is helpful for me to more clearly understand and articulate care in relation to power, the affective, embodied, and material implications of care as power over versus care as power with. And again, when we think about our health systems and certainly the experience of many LGBTQ plus people, but also, of course, people coming from communities who are experiencing other forms of systemic oppression, there are many people and communities who experience our so-called caring institutions as sites of coercion, refusal, exile, and harm. And in these ways, care can be denied, rigidly controlled, stingily rationed, and impossible to access, with often hurtful and sometimes fatal consequences. Here, I find it really helpful as well to learn from prison industrial complex abolition and these analyses of care as carceral. And I think of works like Katie Tastrom, who writes about this idea that this form of carceral control of bodies takes many forms beyond prisons, looking at examples like hospitals, psychiatric wards and psychiatric emergency rooms, treatment centers, nursing homes, foster care, and child protective services, and the family policing system. These institutions are often positioned as sites of care, yet many people don't experience them this way, and again, may consciously choose to avoid them. I can certainly think of people in my own communities, for example, who have very sophisticated strategies for making sure that they don't end up in a psychiatric facility against their consent, because they know that that will not be actually a space of care and support for them. So again, I think this is important to recognize around this taken for granted quality. And I also want to return to my earlier question, what might it feel like to walk into or roll into an ostensibly caring institution and feel an instinctive sense of trust, safety, or belonging? And re-invite you to reflect on why this might feel challenging or even impossible for LGBTQ plus people and many other communities. I also find the concept of epistemic injustice very helpful in thinking about how power differentials shape LGBTQ plus people's experiences of accessing healthcare, and how we are perceived and positioned as subjects within care institutions such as hospitals or clinics. And again, this is a place where we need to think about people's intersecting identities. It is much easier for me to move through the health system as a queer person who also is white, who is non-disabled, who has a PhD. There are many ways in which I am perceived and believed to be a credible narrator of my own experiences in ways that I would experience differently, perhaps if I was racialized as Black, or if I were Indigenous, if I were disabled, if I were visibly poor or unhoused. So really thinking about what does it mean to be navigating health systems as someone who is not perceived as a credible narrator of their experiences. And those of you who know this work, will know the work of Miranda Fricker and others who point to epistemic injustice fundamentally as being a wrong done to someone specifically in their capacity as a knower. And one of the ways this can manifest is through testimonial injustice. So basically, where stereotypes are projected on socially and epistemically marginalized groups in ways that lower their credibility as knowers, while socially and epistemically dominant groups, like physicians, for example, might experience an excess of credibility. But individuals and groups might also experience hermeneutical injustice. So that can look like being excluded from spaces where social meanings are made and legitimated. So that could be like a professional committee, a legislative body, where decisions about care standards and care practices are being made, but also having their styles of expression dismissed as irrational and inappropriate. So this, I think, is certainly an example of the way this top-down power can manifest and disadvantage LGBTQ plus people. And here we see a quote from a paper by Buckman, Ho, and Goldberg, who say, "The effort to behave like a credible patient is only necessary when there is a substantial risk of being perceived as lacking credibility." And I have also found the work of Suslivik and Lett very useful in terms of thinking about resilience in relation to these systems. Certainly the conditions that I am describing demand resilience of LGBTQ plus people, but I tend to be wary of how this concept is mobilized in relation to LGBTQ plus health, because it so often focuses on this idea of creating more resilience as opposed to shifting the conditions that actually demand so much resilience. And Suslivik and Lett talk about this idea of resilience as an adverse event, and they advocate that it is better conceptualized as a form of scar tissue, and that it functions as the result of exposure to traumatic stimuli. And in their paper, they point to the necessity of shifting our focus to the individual and collective mechanisms by which harm is mitigated and prevented, rather than focusing on the after effects of harm. Certainly, I think it's a really worthwhile and important paper to read. Coming back to this thinking from Akemi Nishida and others, I also think it's important to think about care as grassroots resistance, and this is very much a facet of my experiences as a scholar of LGBTQ plus health, but very much also my experiences within these communities. We see that care is often weaponized against communities experiencing systemic oppression, but it can also be used as a weapon in our fights for survival and collective liberation. And I appreciate how Hilma Latino describes this as an infra-political ethics of care. You can find this in Hill's book, Trans Care, but he also elaborates on it in his 2022 book, Side Affects. So he defines this as a form of care that circulates among a beloved community that enables both political resistance and intracommunal survival and resilience. And here he positions care ethics, the embodied person-to-person practices of assistance and support that foster capacities for personal and communal flourishing, as integral to political movement in a way that disrupts any rendering of the private, the ostensible realm of care, from the public, the ostensible realm of political action. And this form of care is the opposite of shunning exile and control, and is ultimately collective. And I think, again, coming back to this idea of the possibilities inherent in care, I also like to think about care as a form of world building. So again, as Nishida reminds us, care can be a means of enacting transformative power for a more just world and way of living. And she argues that it is community-based care or care for one another that lets marginalized communities survive and thrive. And that isn't about letting systems off the hook or moving to an entire community care-based model, but it's more about recognizing the kinds of potentialities that exist and what we can learn from these forms of community-based care. And here I want to connect to the idea of prefiguratism, which is connected to praxis. But basically, care can be prefigurative. So it can be a deliberate experimental implementation of desired future social relations and practices in the here and now. And that's another way of saying we don't have to wait for some far off future to experience the care we need. We can try to find ways to make it now. And that, I think, is another site of intervention, including within our systems, thinking about what we can do as individuals, in systems, in communities, but also, again, to shift our thinking, particularly if we accept that these systems are not broken, they're working as designed. I think that that invites a different way of being and engaging with the kinds of solutions and possibilities that are in front of us. So prefiguratism is but one of many possible tactics we might strategically employ in our efforts towards social change. But I'm interested here in drawing a thread as well with Dillard Wright's notion of possible ethics, because again, prefiguratism and possibility are really ultimately about imagination. They're about world building. And I think that that's actually a really important part of the kind of care ethical work that I want to continue putting into practice in very pragmatic and practical ways. So I want to end with some care praxis-based inquiries. Coming back to that theme of pragmatism, praxis really is simply defined as the application of a theory in a practical way through reflection and action. And I'm curious about how we might apply the ideas and theories I've been exploring today in the context of how we understand and navigate systems of care, whether as patients, clinicians, researchers. And I'm curious what insights and questions arise for you when you think about care in relation to power and control, and what possibilities begin emerging for you when you think of care in relation to resistance and world building. These, for me, are all valuable lines of inquiry in understanding the conditions that exist around us today in relation to LGBTQ plus healthcare, but also to be able to ask ourselves what we might build together to shift into something different for the future. So here I want to say thank you. We have lots of time for questions, and I'll include a couple of links in the chat as well to the most recent book, The Care We Dream Of, explores many of these ideas in depth. And there's also a paper that I published in Essays in Philosophy last year that gets more deeply into this idea of prefiguratism in relation to care ethics. Thank you.
Thank you so much. Wonderful and inspiring talk. Lots of ideas shared with us. I'm hoping the group will not be shy to ask questions or make comments, because I'm sure that their thinking was fueled by your messages and all the amazing references also to a whole range of work. So, so we have ample time for discussion or comments. Donc, si vous avez des questions, des commentaires, vous pouvez aussi les écrire en français et je vais les traduire. I will do live translation of anything written in French. And so we'll open up the floor. Are there comments or questions for our speaker today?
I always like to give people thinking time, and maybe something I'll say just while people contemplate too is I intentionally kept this presentation kind of more engaging in the realm of ideas and theory, because it's also fun for me to talk about things like care ethics and theorizing around care and care practice and systems change. But if there are also if there's a desire to get more into some of the practicalities, or if you have other questions or want to hear stories and examples, I have lots of those to share as well. So just let me know what would best serve your learning in this context.
So we have a first question, which is a question I also had in mind. coming from Corinne Coquillat. She's writing, so to have better systems, we need to design them with LGBT people or a multiplicity of people with different experiences. How can we do that?
Yeah, it's a great question. And I would give it a kind of a yes and answer, which is certainly I think that there are benefits, of course, from involving LGBTQ plus people and other members of communities experiencing systemic oppression. Again, the people who are the most likely to bear the burden of health inequities to be able to have a say in how our systems of care are designed. And also, I think that there is a simultaneous benefit in investing in being able to support the creation of community-led forms of care. So I think there are some interesting models of that at different scales. Here in British Columbia, where I live, there is an organization that is formally embedded within the health system that is called TransCare British Columbia. And they coordinate all of the publicly funded transgender healthcare in the province. And it's been amazing to see the work that they've done over the years that they've been in operation, whole of systems change across the province in terms of educating providers, opening up access to more gender affirming care, supporting community based groups. So that I think is a really interesting model of change, one example of change led within the health system. The majority of their staff, some of whom I know are members of the trans community or LGBTQ plus community more broadly. So I think that as an example, certainly we see patient-oriented care as being a space where bringing that patient voice in can be very useful. And of course, I have my own, perhaps places where I become cautious, I think, of investing whole scale in those kinds of solutions because I'm also interested in what can be created when we think outside of the constraints of existing systems. And that was a shift for me, I would say, in unlearning some of my training as a health services researcher, where I was trained to study systems, but it's been in the years since, as I've studied more deeply about disability justice, prison industrial complex abolition, healing justice, that I've become more adept at thinking about the genealogies of our systems. Like, where did they come from? What are the ideas and assumptions baked into them? And then looking to models, at Casa Salud is another example I'm thinking of that's in, I believe, New Mexico, which is a really fabulous, basically kind of a holistic healthcare clinic that is staffed by a range of clinicians, but they also do very culturally grounded and culturally responsive care. They have harm reduction training. So I think there's also really interesting models that we can look to and that I write about in The Care We Dream Of, where we can see these more kind of grassroots level community solutions. And I think, just as a last example, there's also stories, certainly that circulate in queer and trans communities where community members have really literally taken care into their own hands, right down to the level of sometimes actually learning do-it-yourself surgical provision skills, and having someone who is a physician in the community basically operating their own surgical suite, essentially, kind of in the community for certain kinds of surgeries. So that's, a very extreme example. And there's a particular story I'm thinking of here that's been documented, but there are many ways in which we find to navigate around the systems that don't serve our needs. And all of them, I think, have their benefits and challenges.
Thank you. Thank you for sharing these examples. Very could I say that illustrative of things which can be done. We have another question now from Jennifer Jessup. She's writing, in recent years, training for caregivers in Nova Scotia became more sensitive to power dynamics. So she's giving an example. The unit on behavioral change became behavioral supports. Any thoughts? I don't know if you're familiar with this example and this transformation. We'd love to hear you on this.
Yeah, it's a good question. I don't know about the specific example enough to give an informed answer around that particular shift. But I think it's always a kind of change I would meet with curiosity, right? So you might be changing the words, but are you actually shifting the underlying power dynamics? Like if we're still working in a context of epistemic injustice that is held up by so many facets of the ways that our systems are designed, the ways that providers are trained, the hidden curriculum people are educated into, it's not going to make as big a difference, right, if we call it change or supports. However, if there's that deeper transformative intervention, right, where we're actually shifting mindsets, shifting the relationships and the power dynamics that exist between patients and providers, like I think that's when different kinds of possibilities begin to open up. But it's not enough to just change the words, I guess, is a simple way of saying it. And I'm certain there was more to it than that in this example.
Thanks for sharing this. We have another question from Sarah Cohen. She's writing, it seems that the root of good care is education. Education at all levels of experience. Where would you start? I love that we have amazing questions, amazing talk, amazing questions today. Where should we start in terms of education?
Yeah, I mean, I guess part of my question back is, well, who are we educating and about what, right? Because I think there perhaps is one opportunity is how might we be supported in ways that are culturally relevant to the context in which we find ourselves and the cultures and communities we are part of, that can teach us more about health system navigation and self-advocacy. So I think that is one facet of it. And there's some fantastic resources out there that have been created for LGBTQ plus communities and then different sub-communities. So I'm thinking, for example, of a self-advocacy guide for people who are trans and autistic about how to advocate for themselves and be able to navigate and access care systems. So I think there's that dimension of how do we get better at navigating these incredibly complex systems, because that can be very challenging as a patient just to wrap your head around it, let alone to navigate the inequities and just various structural and systemic barriers that might exist. So I think that's one facet of it. But I think certainly if we're thinking about it at the level of healthcare provider education, there's lots of examples of work that's been done, through, for example, the Association of American Medical Colleges and others saying, look, we need to weave this into all aspects of the curriculum. I was just talking with a friend of mine yesterday who's a nursing student who is also a member of the LGBTQ plus community and who was saying, gosh, we're just not getting this education on LGBTQ plus care integrated throughout our curriculum. We're getting, one lecture in first year, one lecture in second year, but they're not actually giving us really useful clinical information, and me and my classmates actually have questions about what are things we would do in practice. So I think that there's an opportunity to think about, how do we continue doing that work to improve education for healthcare providers. And I think some of that is also about, again, the genealogies of these systems and understanding where they come from and what assumptions and ideas are baked into them. So I think that is another missing piece. And I would say maybe a last theme is to continue committing to unlearning as well. I finished my PhD in 2015, and I have continued learning in a very self-directed way since then. But that time has also included a lot of unlearning for me as I've deepened and broadened my knowledge through continued self-study and training. So I think also getting curious about that as well.
Fascinating. We have a comment from colleague patient partner Frédéric Simard, who's mentioning that the chat is not open. I believe that's a comment. And I want to bring your attention to the fact that this is deliberately the case because we want the questions to be presented in the Q&A tool of Zoom so we can see them, read them out loud for others who cannot see the Q&A. So I hope that answers the comment and helps everyone formulate questions. We have now another question, which I will live translate from Marie-Claude Levasseur. She's a clinical ethicist at Sainte-Justine Hospital, pediatric hospital of Université de Montréal. And this will explain the question. She's asking, can you give us your perspective on the specific needs of minors who also navigate healthcare systems too? So any thoughts to share on, I know it's a big question, but it's a really important topic.
Yeah, and I think it's also a highly politicized question right now, and one in which there is a great deal of not just misinformation, but disinformation that's circulating, and I think this is particularly the case for young transgender people. So um, I want to name that really explicitly, not to suggest that that's implicit in this question specifically, but when I think about the needs of LGBTQ plus young people, I think about the ways in which many young people, and particularly those who are trans or non-binary, might be experiencing a particular harm right now, because in the Canadian and US context, certainly the UK, where we're seeing moves to limit access to gender affirming care, to mandate that their teachers not honor their names or pronouns they might use at school, or force disclosure to their parents, who they may not be out to for reasons of safety. And I think this is incredibly concerning to me, not just because it goes against a body of evidence that is telling us, what kinds of care will actually support not just the well-being, but the survival of young people. But I also very much believe that we live and work in contexts of childism and ageism, and I think a lot about adult supremacy, including as a parent to 3 young children, and what are the ways in which I, as an adult, have internalized relations of dominance that I enact against children and young people and deny them their autonomy and their decision making. And that's going to look different for, my 2-year-old twins than it is going to for an 18-year-old or a 16-year-old or a 12-year-old or a 9-year-old. But I think we do a profound disservice to young people a lot of the time by not respecting their perspective, their self-knowledge, and supporting them to access the care that they need. And I think that is imperative that we fight the misinformation and disinformation that is going around right now, where people are talking about, for example, surgical interventions being done on trans children that just don't happen. It is not a standard of care. And I think that that's incredibly problematic, and it is dangerous. And it is part of a larger political strategy that we need to fight back against. And I think we cannot sleep on that. I live in a small semi-rural community where we have a small but vocal anti-trans community. And it's a pretty scary kind of community organizing that is happening on the right now. And I think we need to be awake and alert to that. And I think that that raises vital ethical questions and questions of solidarity, including with young people.
Amazing. Thank you for sharing your view on this so important topic. We now have a question from Ingrid Kovich, who is chair of the MUHC, the McGill University Health Center Patients Committee. And she's sharing, we are in the process of building a working group to address the needs of the LGBTQ2+ community. What are some practical and achievable goals to make our institution and the care we provide more safe, welcoming, and gender affirming?
Yeah, well, first I want to say thank you for the work that you're doing, in terms of your own change work in the health system. That can be a pretty heavy lift sometimes, and it's really necessary. And I'm happy to connect offline if you want to email me through my website. And my email address is there. You can just email me through a form. It's just zenasharman.com. But I mentioned that specifically because I have a set of resources that I'm happy to share from a range of organizations that talk about some of these kind of more organizational level interventions that can be made. So I'm a big fan of not reinventing the wheel, and of course, adapting to your local context. But again, really welcome hearing from you around that, because there's been some good work that's done around, policy interventions, for example, considerations around staff training, the organization of our spaces, that kind of thing. But I think importantly as well, it's really thinking about intersectionality in relation to LGBTQ plus health. And so how do we make sure that, you're not just talking to people like me, right? Who maybe I'm a member of the queer community, but I'm not bearing the brunt of systemic oppression in the ways that other people in my community might be by virtue of racialization, disability or neurodiversity, poverty, other kinds of things that might impact their social determinants of health. So I think really taking an intersectional perspective in terms of, who are you designing for, and what are the needs that you're really trying to meet here?
All right, thank you. I was looking at the next question from Victoria Dudankova. She's asking, I think, your opinion on the CIHR definition of women's health, I believe. And basically, it would be very hard to do a live translation of this piece of text. But it seems like the CIHR is defining women's health in a way, in diverse ways. In the context of a national initiative for women's health, we consider the concept to be evolutive or evolving in ways that take into account intersecting aspects of sex and gender. The term refers to the health and well-being from a kind of physical, biological, genetic, psychological, emotional, cultural, spiritual aspects and steps of life in the context of intersecting preoccupations unique to our bodies, our roles, our social situations and identities. So it's hard to translate, but you're getting maybe a gist of this question. And basically, far from being limited to a binary view of sex and gender, the initiative takes into account various needs and experiences of people who identify or self-identify as woman, girl, intersex, or, oops, I move my cursor. Sorry, identity, gender, which is underrepresented, notably without being limited to be spiritual person, trans, and non-binary, and gender fluid or non-agendered. So what the question would be your reaction to this definition, which I tried to translate as much as I could.
The good
What
news
are
is
the
I was actually reading that definition in English yesterday, so
Oh,
it's fresh in my mind because if I'm catching this right, it's the definition of women from the National Women's Health Research Initiative,
exactly.
which is
Yeah.
a federally funded investment that came out of the 2021 federal budget, but that is being funded through the Canadian Institutes of Health Research and a number of funding initiatives. So, I mean, what I can say is, I think there are, I'm sure, really important underlying strategic reasons why they wanted to write a definition of women's health that is inclusive. Because, again, I think what I'm anticipating, and I don't know enough about the genesis of this particular initiative and the definition, but I think a desire to say, we're not just looking at the health of cisgender women, right? Of women who, like myself, people guessed when I was born, they looked at my external genitalia and were like, yep, that's a girl. And, lo and behold, I felt like a girl and then a woman through my whole life. And I also think, it can get a little bit tricky sometimes when you're saying, hey, we're talking about women, but also it includes non-binary people, for example, because I know and love many non-binary people, including my own partner, who say, well, hey, I'm not a woman, like I'm non-binary. That's kind of the whole point, right? So, I think perhaps this is a place where we are navigating maybe a difference between how do we honor how people identify and where they might sit and situate themselves in relation to certain categories, which will vary, right, person to person. But I think also the strategic imperative of saying, well, if you're putting $20 million into women's health research and you're trying to find a way to make that somewhat more inclusive, okay, do that, right? I mean, I think that can lead to benefits as well. So I don't think that there's an easy or simple answer, but I think, as always, it's like, what are you trying to do, and what are the pros and cons of inevitably when we make a definition, we include others and some, and we exclude others. And I think there are probably a range of ways I would answer that question depending on the context and who the asker is.
The questions and the answers are so fascinating. I was losing sight of time, and we're unfortunately we're running out of time, or we're coming to the end of the hour. So I want to thank you very, very dearly for your amazing talk and wonderful and elaborate answers to all these relevant questions. It's amazing answers, so thoughtful and so enriching to hear your perspective and your ideas on how we could do better, how we can move forward and become more inclusive as people and as health systems also. So I'm sorry we cannot go through the entire list of questions today. So thank you again, Zena. And I want to take a moment to announce the next lecture before we leave each other. September 26th at noon, we will hear from Luc Bégin, professeur titulaire, faculté de philo, directeur de l'Institut d'éthique appliquée, l'IDEA, à l'Université Laval, aussi directeur de la revue Éthique publique. And the talk will be in hybrid mode, and the title is Risque éthique et culture attentive à l'éthique, or Ethical Risk and a Culture Attentive to Ethics. So we'll see you then. Thanks again to our speaker today, and we're looking forward to seeing you after hopefully a nice and restful summer. Merci. Thank you again.
Merci. Thank you so much.